I want to go to Dr. Jen Caudle on what she makes of this right now. Doctor, good to have you back. You know, the testing is one thing, the promising news out of, what we're hearing with Gilead Sciences, the progress we're told that Pfizer and others are making on ancillary treatments. That's a lot of good, but are we getting ahead of our medical skis? What do you think?
Well, this is a lot of good, and I'm hopeful about the Gilead drug that we're talking about, remdesivir. I still have yet to read about it and learn about the studies, and I think they're going to be releasing some data soon. Look, we're all hopeful, Neil. Who isn't hopeful? We do want a treatment. We do want to eventually get to a vaccine. We want all of these things. All of us do. So I think being cautiously optimistic is always reasonable, but again, we always have to follow the data. You were talking about testing with your prior guests, and that's sort of a thing that's sort of on our minds these days. No, I think we do need more testing. I know we do. I'm seeing patients through telemedicine now on my computer. Just saw a patient yesterday who had symptoms who really had a hard time getting tested. And that still is happening on the ground. And I would like to see that go away. Many of us would. And more testing overall to help us figure out how we can best and safest, most safely get back and to be healthy.
I don't know the exact number, Doctor, you probably do, but I think it's around or less than 2% of our population that has been tested. It might be more, it might be less in certain states. What is a comfortable percentage for you? I'm sure it does vary by the severity of the state, but I'm sure it's not 2%.
It's certainly more than that. I think, can I give you an exact number? I don't know that I can give you an exact number. And I do think there are models. I know there are models out there that tell us best practices, what we need to have. We need to be following those models. But the general idea and what's most important to remember is that we need more testing than that. We need the availability of testing. What I see on the ground as a doctor is honestly initially, family medicine. I'm an associate professor at Rowan University. We have a great team of faculty members, and I'm part of the university. We have great infrastructure, and there was still a little bit of like, okay, where do we get the test? Who do we test? How can we test? And we're part of an institution. I often thought early on about those docs in private practice, et cetera, trying to figure out how to navigate all of this. Testing needs to be more widespread, but also, Neil, we need other things too, right? We need sort of our public health initiatives to be in place. We can't just test people and not have a plan with what to do when people are positive. We need to have public health officials being able to contact trace and sort of, administer and sort of dictate and not dictate, that doesn't sound right, but kind of guide us into isolation and really make sure we're keeping track of all this. This is really a whole large effort. It's like a machine, if you will. We need all these parts to be in place to make sure that this machine is working properly.
Well said. Dr. Caudle, thank you. Very good catching up with you. I appreciate it.